First, I just want to welcome everyone to the USC Spine Center webinar. We're starting a new thing today. This is the first in a series of webinars. So many of you have been to some of our webinars before, and we actually started with live dinners until we had the COVID-19. And now we moved to webinars. And what we are going to do starting today is every month deliver a webinar on a different topic within spine. And so we'll make sure that all of you get the announcements so you can see if the topic is of interest. But each month it'll be a different topic. I think in September we might be doing two presentations, but it's pretty much one a month until May, so that you'll get sort of a comprehensive view of kind of the overview of spine. We'll have some guest speakers and things like that. So with that, I want to welcome you to this webinar as well as future webinars, and hope you find this exciting. And certainly if you have feedback overall to the webinars, feel free to contact us. Feel free to contact Betsy, our administrator. She runs our spine center. She's our director, and she kind of sets everything up. There is the Q&A function. So during our talks, if you want to ask questions, you can just basically type it in the Q&A box, and we'll try to leave at least 10 minutes at the end of the webinar for questions that you might have. And so I'm going to get started. So I'm going to share my screen, and I'm going to ask Betsy to let me know if I share the wrong screen.
It's right. I see it.
Okay. And so you see just the big slide, is that correct?
Correct.
All right, thank you. So I'd like to welcome everyone. This is sort of the first in our series of webinars that we'll be going through to May. We're from the USC Spine Center. These are the folks in the USC Spine Center. My name's Jeff Wang, and I'm the guy here in the bottom right side. And Patrick Hsieh, who's also a spine surgeon, is right here. But I just want to give you an idea of all of the people in our team. This is Tom Chen. He's a neurosurgeon spine surgeon. This is David Chang. He's one of our physiatrists and interventionalists. This is Ray Ha. He's in the orthopedic side. Patrick, you'll hear from a little bit later. This is John Liu. He's one of the co-directors. He's my co-partner. This is Chris Arnellis. John's a surgeon. Chris is an interventionalist. Mark Spoonermore is another spine surgeon, and Gene Techmeister, who really is kind of organized all the topics for this curriculum for our webinar series. He's an interventionalist, and he just joined us, and this is me. We'd like to welcome you. As you may or may not know, we have a multidisciplinary approach to spine because the vast majority of people with spinal disorders need a variety of conservative treatments as well as operative treatments and interventions. And so we do have a multidisciplinary approach. And if you have a patient that has a spinal issue and you'd like to get some advice or some treatments, feel free to send them over. We'll make sure we direct them to the right person as far as for conservative care, interventions, and then ultimately with surgery. We cover the whole gamut of spine surgery. We feel like we're able to customize the treatment programs to every patient's sort of symptoms and their pathology and their imaging studies. And we feel that we do have an expertise in all areas. And that's the nice thing about having a whole team of specialists. We basically cover all areas of the spine, whether it's the cervical spine, the lumbar spine, minimally invasive, deformity, tumors, and trauma. We feel like we cover everything. We also cover the interventional side because, as I said, the vast majority of people with spinal disorders actually end up not needing spine surgery, but a lot of them we can sort of alleviate their symptoms with conservative care. If it does come to surgery, we certainly have all the latest technology to allow us to do minimally invasive approaches if appropriate. We have all the technology to allow us to sort of use the latest and greatest devices and interventions for our patients with sort of minimal incisions. We also feel that we want to be recognized worldwide as not just treating patients, but being a leading academic spine center. And we sort of have three areas that we focus on. First is multidisciplinary patient care. Second is spine education for the next generation, because we are a teaching program. We have spine fellows, and we have residents in orthopedics and neurosurgery, as well as physiatry fellows. And we want to be on the cutting edge of innovative spine research. If you look at our facilities, we have our university hospital downtown. We also have the Verdugo Hills Hospital. which is up in La Cañada, and that's where we do our primary elective spine surgeries. We do have locations in Arcadia, Beverly Hills, El Segundo, Garfield, Good Samaritan, kind of all throughout downtown Los Angeles, Pasadena, Ridgecrest, and Verdugo Hills. So we do have a fairly large footprint that hopefully would allow your patients easy access if they need a spine consult. We feel that we also can offer virtual visits. We have the technology to do that, as many of you are probably doing telemedicine, and we'd be happy to set that up with any of our specialists if you so desire. And I think a big part of our program is our diversity as far as being educators. We do have the residency in neurosurgery and orthopedics. They rotate through our spine service. We do have a spine surgery fellowship. We also have a medical spine fellowship, and we're always teaching medical students. And we have a vast number of international surgeons and PhD researchers that visit our spine center, spend a year or two with us to kind of learn the latest techniques and to do cutting edge research. We also are involved in a lot of international education. Many of us have leadership positions in a lot of the spine societies. And this is just a picture of 3 of us surgeons doing one of the first cadaver spine surgery courses in China. This was a huge event. And well, before the pandemic, we were holding educational courses throughout the world, and hopefully that will start up again. But we do have a fairly robust international program. We see patients from the international areas. We do have an initiative to build a spine center within China. And we have a vast number of relationships with other Chinese universities and other universities throughout the world for our education and research programs. We do have a very robust research center. We have a lot of studies going on for disc generation, spinal cord injuries. We're collecting a lot of outcomes and using a lot of sort of the latest and greatest to try and regenerate the disc. And obviously we can get you more information. And I think some of the talks you'll see in our spine series will actually cover some of the research that we're doing, both basic science and on the clinical side. And then we'd like to just alert you of the date, as long as we're able to. We usually hold a yearly spine symposium, and we're targeting in Hawaii in June of 2021 to hold our USC Spine Symposium, and we'll make sure that you all get information on that, and you're certainly welcome to attend, and hope you consider it. Hopefully that we'll be able to travel safely at that time. With that, we're going to start our program for tonight. I'm going to spend about 15 to 20 minutes talking about the cervical spine, which is a very kind of a particular area of interest of mine. And then I'm going to turn it over to Dr. Hsieh, who's going to talk about spinal cord injury for about another 15, 20 minutes. And then we'll hope to finish before the hour and allow 10 minutes of questions. And again, feel free to type in questions as they come up, and we'll try to hit those once we're done. But I want to talk about cervical spinal disorders, and they're so much different than lumbar spine. People tend to lump them all together, that the spine is the spine. These are my disclosures. I don't feel that any of these will affect what I'm about to talk to you tonight. But when we think of back pain and neck pain, this is a pretty common problem. We probably have patients that have these types of symptoms, and we may experience this ourselves one day. But I think we're all aware this is just an enormous problem. And if you look at the Bill and Melinda Gates Foundation, there's some startling statistics just here in the United States that really translates worldwide, that a vast majority of people have a huge chance of becoming disabled within their working ages. And within the United States, it's 25% of everyone between the working ages of 20 to 65 are going to become disabled. And that's shocking to me. And the #1 cause worldwide is spinal impairment. And if you look at back and neck pain, that is the #1 cause of disability worldwide. You know, it used to be, I think, like cardiovascular disease, diabetes, things like that. Those are all decreasing. The problem with spine-related disability, this is only increasing. In the past 50 years, it's increased by 300%. And so these are the types of problems I think we're all going to see. We all see them on a daily basis, and we're going to need to deal with that because it's increasing all the time. The thing to understand about the cervical spine, when we look at the spine, we tend to think of it all together. So we look at this picture, we see the head, we see the neck, we see the thoracic spine. But there's a huge difference in my mind between the cervical spine and the biomechanics versus the lumbar spine. And I would encourage you to think of them differently. And that's going to be sort of the mission of my talk, is to give you sort of an understanding of the cervical spine. These are the 5 areas that I want to cover during my talk. I'm going to first talk about the cervical spine and kind of see how it's different from the lumbar spine. And so the first part of the cervical spine being different is just the overall anatomy, right? When we think of the spinal cord, we all know that the spinal cord runs from C1 to L1, right? I mean, it can vary depending on the individual. So when we look at pathology that affects the spine, if we're dealing with like a lumbar disc at L23, L34, L45, or L5S1, and you're compressing the nerves, you're compressing the cauda equina. Now that can be serious, but on a very basic level, you are still only compressing peripheral nerves. Whereas if you have the same disc herniation in the neck, in the cervical spine, and you're compressing against the central structures, you're really compressing against the spinal cord. And so if we're doing surgery, we are very much more cautious when we're dealing with the neck than the low back because the spinal cord is much more sensitive. And the other thing about it is that if you have a condition, a herniated disc is not a herniated disc, meaning a herniated disc in the neck can be compressing the spinal cord. A herniated disc in the low back, it can be quite large, but in the end, it's really just compressing potentially the cauda equina, but more likely a peripheral nerve, which is kind of more robust. And so the conditions in the neck can be more serious, and we tend to prioritize the cervical spine. And so we take them a little bit more seriously, but it also can affect things in other ways. And for example, we all know that in the low back, when you get stenosis, if you bend forward a little bit, it gives you a little bit more room. Well, the position of your spine can give your nerves a little bit more room or can give it less room. If you have cervical stenosis, even if they're not grossly symptomatic, you have to be very careful because if that patient is going in for hip surgery or going in for GI surgery or leg surgery, and they're going to be intubated and their neck's going to be in a certain position, if they have a lot of stenosis there, even though it's asymptomatic, if they're positioned the wrong way, that could potentially cause a problem. So it just gives you an idea that the neck is a little bit more serious than the low back. The other thing that differentiates the neck from the lumbar spine is when you think of the lumbar spine, there's just more stress on the lower spine. When you think about the body weight, and if you look at this sort of red box, all of this body weight is putting pressure on the lumbar spine, right? And so any disc in the lumbar spine is seeing all the pressure from the head, the neck, and the upper body and the torso, and there's more body weight there. Whereas, and obviously if you're an obese patient, you're putting much more stress on your lumbar spine. However, when you're dealing with the cervical spine, you're just dealing with the head, right? And the head weighs about 10 to 15 pounds. There are some people that have bigger heads than others, but it's only going to weigh a certain amount of weight. And if you're obese, your head probably could be a little bit bigger, but the neck is just not seeing the same biomechanical stress that we're seeing in the lumbar spine. And so that's why I think there's a huge difference in the pathology between the cervical and the lumbar spine. In the lumbar spine, we see a lot of arthritis and we see a lot of patients that have back pain, right? That's pretty common. Back pain is very, very common with arthritis, and back pain is just a generalized complaint. It can be associated with a multitude of issues. We all know it's not just arthritis in the low back. You can be obese, you can be overweight, you can be out of shape, it can be a muscle issue. The neck pain is less of an issue. We can see patients with a lot of arthritis in the neck, and they can be very, very asymptomatic. And the other thing is that we're not doing surgery in the neck usually for neck pain. I know that sounds kind of odd, but you know, there are lots of surgeries that people do in the lumbar spine for back pain. But in the neck, if we're thinking of surgery, we're more thinking about neurological decompression to alleviate neurological compression. We're not really talking about doing a lot of fusions for neck pain. And so we're looking at a little bit of a different sort of disorder. The other thing is that when it comes to surgery, cervical patients just do better. Maybe it's because there's more blood supply to the brain and the neck, and they just heal better. There's more reliable results with outcomes. The pathology is usually clear cut because we're not just operating for neck pain. You know, you have to have radiculopathy, you have myelopathy, you have to have like very discrete pathology. Whereas the low back, it's sometimes hard to distinguish that pathology. We're typically dealing with cervical surgeries for neurologic compression. There's better healing rates, perhaps less problems in the future because there's less biomechanical stress on the necks. And the axial pain, if you get arthritis in the neck, a lot of patients don't have a lot of like neck pain from that. So it's usually less of a problem, and we're not doing surgeries for neck pain. And so when there's a big debate about spine issues, most of the controversy that you see in the magazines and in the press is really about back pain, right? And when you see all these advertisements and things like that, it's really, really more towards the back pain. When it comes to the neck, you're really dealing with more focal pathology. The other thing, when you have a patient with a neck problem, the symptoms can vary. And so what I like to do is I like to simplify things. So if you have a patient, they have a neck problem, they can typically come in with neck pain or they can have arm pain. And I like to divide it into neck pain and arm pain. The reason being is if they have neck pain, then I'm looking for potential pain generators that are causing neck pain, such as the structures of the spine, arthritis in the disc, facet joint arthritis, instability, a muscle strain. Maybe their sagittal balance and alignment is off, or they have a fracture in the neck, they have a tumor in the neck. But if they have primarily neck pain, I'm really looking for something structural in the neck that usually causes that neck pain. On the other hand, if they have arm pain, I'm usually thinking about the nerves, right? I'm thinking about a herniated disc pinching a nerve, spinal cord compression, foraminal stenosis, bone spur, or if it's a tumor that's compressing the nerve, instability compressing the nerve, anything pushing on the nerves. That typically gives you the arm pain. And so I like to kind of delineate and separate those two. You have to do a good physical exam, and we're not going to cover how to do good physical exam because I think everyone can do a good physical exam, but you need to know how to do a good neurological exam, understand the dermatomes with the different cervical roots. For example, understand C5 goes to the deltoid, C6 comes down to the thumb and the first finger, C7 is the triceps down to the middle finger. Get a good reflexes, and you have to relax the patient. Every day I go to clinic, the residents will see a patient, come out and present it to me, and they'll say the reflexes are normal. I'll walk in there, and there's at least one patient a day that I'll have the patient relax, and I'll have them really relax, and I will get increased reflexes. It's hard to get the reflex unless the patient is very relaxed. Hoffman's reflex, you flick their finger and see if they have a contraction. That's an upper motor neuron sign. It's kind of like the Babinski's reflex of the upper extremities. It's very important to test for that. I also ask them about their gait, look at their balance and see if they walk with an unsteady gait, and look at their alignment, see if their neck is kind of positioned forward. I think those are the kind of things that I would recommend looking at. I would say the biggest advance that we've seen in the last 10 years has been we're more focused on the alignment of the lumbar and the cervical spine. And what we mean by that is that if your neck is well aligned, your muscles are very well balanced, they don't get fatigued. If you are pitched forward and you have what we call a positive sagittal balance, your muscles get very, very weak, they can decompensate. This is a huge source of disability. And we now know the importance of this. And we also know that if we are going to try and restore a good outcome, we need to try and restore the alignment. And so if we're looking at a post-op patient, we want them to end up with their alignment like this on the left side rather than what you see on the right side. These are the red flags. Obviously, you have to worry about infection, tumor, fevers, chills, things like that, if they're an IV drug user, things like that. But I would also say that the biggest red flag is don't miss cervical myelopathy. Cervical myelopathy, such as what you see in this MRI, can oftentimes be painless. And these patients, they don't have any neck pain. They have bad spinal cord compression. Their typical symptoms are they're losing their balance, losing their coordination, they're dropping things, they're buttoning buttons or putting earrings in is kind of compromised, their handwriting is off, and they will say that they walk and they're unsteady on their gait. When you do the physical exam, see if they can balance on their toes. Look at a Hoffman's reflex, see if they're hyperreflexic, if they have a Babinski's, if they have sustained clonus, or if they have finger issues where their fingers lock up and their fingers stay like sort of extended. Those are signs on the physical exam that the patient has myelopathy, and that's a very, very serious condition. If they have cervical myelopathy, you need to order an MRI. You need to catch it. There are countless times I'm in clinic, patients coming to me for back problems, and I end up getting a cervical MRI because I'm worried about what I'm finding on their exam. If I see upper motor neuron signs, I know that it has to be something in the brain, has to be something in the cervical spine. And we know this is a deteriorating condition. If they have this, the recommendations are most likely going to be for surgery, okay? As far as the workup, you probably know a lot about this, but I look at the x-rays, I look at the discs, the bones, I look at the discs between the bones, I look at the alignment. I want to see if the bodies line up, if they line up in the front, they line up in the back, do they line up in the very back? That's the space available for the spinal cord. I want to look at their AP view. I want to make sure there's no rotation of the spinous processes, and I want to look at the facet joints and make sure they are symmetrical. I want to look at the odontoid. I don't want to ignore the cranial cervical junction. I want to see if there's any arthritis. A lot of patients have C1, C2 facet arthritis, and that can lead to sort of occipital headaches and things like that. You want to make sure that you see all the way down to the junction of C7, T1, especially if the patient's had a trauma. Here's a patient that you don't really see the discs as well. Here you see the disc, but you don't see the disc as well. Here, this patient had an uninstrumented fusion in the past. This is a rheumatoid that has a little bit of cranial settling, and so the odontoid is pretty close to the occiput, and you can see there's stair stepping, there's arthritis in the discs, and the discs are fairly collapsed. This is a patient that has a kyphotic deformity with significant arthritis here, and they're basically collapsed at that level. And here's a patient that has evolved in a trauma, and you can see there's a malalignment here. This patient has a jump facet here, and oftentimes these can be missed, but you can see that the alignment is off. Don't ignore the cranial cervical junction, C1, C2. It's hard to see the ring of the odontoid here, or the ring of C1 on the odontoid, but when this patient with rheumatoid arthritis flexes forward, you can see that the lanto-dens interval is increased, and this patient has significant C1, C2 instability, which is very commonly seen in arthritis. And then look at their alignment, and when you look at their x-rays, do this measurement. This is a quick and dirty measurement, and look at the middle of C2 to the back of C7. It should be within 4 centimeters. If it's less than 4 centimeters, it's normal. If it's more than 4 centimeters, then they're off balance, and these patients don't do well, and that can be a source of their pain. I try to get these patients into physical therapy, and this just shows their pain scores are significantly higher if their sagittal balance is off. The MRI is critical. It allows you to see the spinal cord. Here's an example on the left of a herniated disc with spinal cord signal. This patient has spinal contusions. This is a patient that has a central cord syndrome, no fracture, but they were involved in a trauma, and you can see there's increased signal here in the spinal cord. And here's a patient that has cranial settling. The odontoid is kind of poking up into the foramen magnum, probably has rheumatoid arthritis. I do get CT scans. Sometimes when you look at this on the left side, this looks like disc, but this is actually bone. This is calcified ligament. It looks like disc material, but it's actually bone, and you can sort of see it on the CAT scan. And a lot of times on the MRI, you're not going to differentiate bone from disc. This looks like a big disc herniation, but when you get the CT myelogram, you see it's not a disc at all. It's actually bone. And this is a calcified ligament that's causing significant spinal cord compression. It's important for us if we're doing surgery to understand what's bone and what's not. As far as conservative treatments, there's a whole host of things out there, and I'm a big believer in surgery as the last step. But what I do talk to my patients a lot about is trying conservative treatments, but I also try to convey to them that the conservative treatments don't change the anatomy. And I use this crazy example. I always say, if we locked you in your house and made you do therapy for 24 hours a day, you did physical therapy, you took medications, you had 12 epidural injections that day, you had chiropractic care, you had acupuncture, and you do that all day, and you do an MRI or X-ray that night, it's going to look the same. And if the next day we repeat it, we lock you in the house, we make you do physical therapy, chiropractic treatment, add in magnet treatments, meditation, do another 12 epidural injections, and at the end of that day, you do another MRI or X-ray, it's going to look exactly the same. It doesn't mean that every patient needs to go to surgery, but it's important for the patients to understand that the conservative treatment is trying to help them with their symptoms, but doesn't necessarily change the anatomy, but it could give them time, right? I usually try to direct the treatment at the pain generator. Again, if they think they have neck pain, I'm going to put them in physical therapy, look at the spinal structures. The pain guys can do interventions in the facet joints, trigger points, and things like that. Work on their posture and try to make sure that they're in good alignment. If it's arm pain, then I'm looking at the nerves, then I'm thinking about epidurals, nerve root blocks. Obviously, there can be overlapping symptoms, but I try to direct the conservative treatment at where I think what I think the pain generator is. And I think that conservative treatments are the first option. Big believer in physical therapy. Whether you do physical therapy, chiropractic treatment, there's active versus passive. Passive is you lie around, you get massage, manipulation, heat, ice, ultrasound, feels good, doesn't make you stronger. The active strengthening exercises, making them stronger, I'm a big believer in that. We do get EMG studies sometimes to sort out peripheral nerve issues that can overlap with cervical spine issues, and I always look at surgery as the last step. And in the last 2 minutes that I have, I do want to just kind of reiterate cervical myelopathy. It's important to detect it. There are no conservative treatments for cervical myelopathy. And what I mean by that is there's no conservative treatments that alter the natural history. It doesn't mean you can't try these, okay? But you have to understand that this is a very serious condition. There's a classification for myelopathy for mild, moderate, and severe. If you have moderate and severe, we are obligated as spine surgeons to talk about surgery for these patients. If they have mild myelopathy, we either have to watch them very closely, which means I follow them every 6 months, and you have to at least mention surgery. And those are the current guidelines. That's how serious of a problem this is. Because if you wait for them to deteriorate, they may not recover. And that's the problem. This is going to sound backwards, but sometimes when it comes to cervical myelopathy, the most conservative treatment is surgery because you want to prevent the deterioration. And so this is something that you cannot miss. I'm going to spend the last minute talking about surgical options. I look at the surgery as a patient's choice. My concern, if they have myelopathy, that's one of the few times that I will sit there and recommend surgery, but usually I let the patient, even then it's the patient's choice. I can tell you that the best reason for surgery is quality of life. And that's kind of a ubiquitous term. It's overall assessment of how they're doing. I get concerned about a list. If they make a surgery of do surgery, not to do surgery, and they start making a list, and once they get down to number 23, for me, I always tell them, I don't want you making a surgery decision based on what's number 23 on whether to do it or not. You should base your decision on whether to do surgery or not to do surgery on number 1, and that is quality of life. If you're happy with your life, you're not deteriorating, you're doing the things you want to do, and you're feeling fine, you don't need surgery. If you're not happy with your life, you're not happy with your impairments, you're not doing the things you want to do, it's one of the best reasons to have surgery. As far as what I do, if they have neck pain and they just have arthritis, I will rarely recommend surgery. I rarely do fusions for neck pain. The exception will be if they have instability, they have a fracture or subluxation, or if they have headaches with C1, C2 degeneration and they've had relief temporarily with an injection in C1, C2. For neural elements, we do surgery a lot. We decompress and sometimes we have to stabilize them. This is a patient, the x-rays are pretty normal except for some degeneration. This patient has foraminal stenosis and they have radiculopathy at 2 levels. Since the compression is just in the foramen, we can do a small, minimally invasive microforaminotomy, such as pictured here, and through a small incision, we can open up that foramen for the nerve root, and that's if it's indicated for that. Here's a patient that has a 1-level disc herniation. We're about to do surgery on them, but this would be a great candidate. The discs are not too arthritic for a disc replacement, taking the pressure off the spinal cord and the nerves and preserving motion, and that's a great surgery for a lot of patients. Here's a patient with cervical myelopathy. They have good motion. There's a contusion in the cord. It's kind of hard to see it here. And what you can see, if you look on the right side of the screen, there's a lot of compression of the spinal cord. There's a lot of narrowing. The patient has myelopathy, and there's a contusion in the cord. This patient has myelopathy but doesn't have any neck pain. This is a great patient for a laminoplasty, where I went in the back, I opened up the lamina to make more room, but I didn't have to do a fusion. And post-operatively, you can see they still retain their motion. So we did not have to restrict any of their motion. We just gave their spinal cord more room. However, there are many patients that have contusions and a lot of arthritis that still need to have fusions. There are a lot of people that have multi-level degeneration. Their chin is on their chest, they're bent forward, their alignment, as we talked about their alignment being forward, they're very much forward. And this is the post-op x-ray on the left, on the right. You can see we had to do a big front back surgery. We corrected the alignment, took all the pressure off the spinal cord. And this is a huge surgery here. This is a patient that has chin on chest deformity. They can't lift their chin off their chest. We basically had to do an osteotomy, and I don't have time to show you the intraoperative, but here we had to basically cut their spine and reposition their head. This is pre-op and this is post-op, and they're in a lot better situation. When we do the surgery, we do use image-guided navigation. It allows us to put our hardware and screws in the right spot. It allows me, and this is a case example where we used it, it kind of gives us an idea of where we are with the spine. So when we have to do complicated spine surgeries, this gives us an idea of where we're at. So in summary, I think if you look at the spine, think of the neck, and the cervical spine is different from the lumbar spine. We have to be very, very careful when working up spinal disorders because we're dealing with the spinal cord, and these issues can be serious. And I think if we sometimes have to do these big reconstructive surgeries, at least the success rates in the neck are much higher than the low back. With that, I want to thank you for your attention. I do want to turn the screen over to Dr. Hsieh, who's going to talk about spinal cord injuries. And Betsy, do I need to do anything or do you do it?
Nope, I've already made him a co-host, so Dr.
Great. I'm going to mute myself and turn my camera off.
All right, thanks, Jeff. Let me share my screen, and so I'll get started on my presentation here. Okay, can everyone see my screen?
Yes, we can see it.
Okay. All right, welcome, everyone. Thank you for spending your evening with us, and I hope this webinar will be informative to you in your treatment of patients. So we're going to turn 180 degrees from just topic and talk about spinal cord injury. Here are my disclosures. There's no direct conflict with the content of this talk. So in this talk, it's a little bit hard to prepare a talk that can have a broad audience, but I thought I would give an overview of some of the etiology, disease diagnosis, and prognosis, as well as treatment of spinal cord injury, and talk a little bit about some of the recent as well as up-and-coming clinical trials for traumatic spinal cord injury. So spinal cord injury, as the name implies, is any injury that is directed at the spinal cord. So most of the time, when we're talking about spinal cord injury, we're talking about acute spinal cord injury related to trauma. In some cases, tumor infections can be rapidly evolving that can lead to acute spinal cord injury. Rarely are you going to see a degenerative spine condition that's going to cause an acute spinal cord injury, but there are some unique situations such as central cord syndrome or bronze-acquired syndrome that can be caused by degenerative spine disease. But it's also important what Jeff had talked about in the previous talk, that it's very easily for us to ignore the importance of spinal cord injury in the form of myelopathy. So these are insidious spinal cord injury that occurs from degenerative conditions, and we coined these myelopathy. Most of the time, it's related to degenerative conditions, with some cases that can be caused by tumors or infection in a more insidious fashion. So, spinal cord injury typically is going to be related to some form of trauma. These are trauma with significant velocity, impact. The most common history you're going to have in these patients are going to be motor vehicle accident, motorcycle accident, falls from, ladders or multiple floors. Diving into a pool while you've had a few beer is a common history that we'll get for patients with spinal cord injury. In some situations, though, even a low-pack trauma can place a patient at high risk for spinal cord injury, and these are usually related to the patients who have an anatomy propensity that can lead to spine traumas that are more significant. Typically, these are elderly patients with osteoporosis, or they already have some form of underlying spinal instability that is exacerbated by any low impact trauma. So as you may all be aware, spinal cord injury is a very devastating disease. While it's not that common, it affects anywhere from 11 to up to 15,000 patients per year. Unfortunately, most of these patients are young adults and individuals that have a long life ahead of them. With these injuries, oftentimes, however, it leads to a lifetime disability that can be either quadriplegia or paraplegia. It's also a very costly injury, not only for the individuals and the family involved. It's very costly from a socioeconomic standpoint. As you can see, the cost of care for these patients ranges from hundreds of thousands of dollars to millions of dollars throughout their lifetime. So anything that we could do to prevent these injuries and to improve the functional outcome of these patients can have tremendous impact not only on the patient and the family, as well as from a healthcare socioeconomical perspective. So, in terms of evaluation and management of spinal cord injury, obviously, I think for most diseases, it starts with a history and examination, but it's important to remember, but because these cases involve significant traumatic injury, that like many traumatic injuries, the airways, the circulations have to be stabilized first before we even get to the history and examination, because these patients could be quite sick and have significant injuries. In terms of history, generally history is fairly straightforward in terms of spinal cord injury. Most of these patients are going to have some form of trauma that you can identify the mechanism of injury. The examination should be much more thorough and specific to a spinal cord injury examination. And really the standard for spinal cord injury patient examination is not your typical molar sensory examination that we would perform in most physical examination or evaluation of degenerative spine diseases. The standard for this examination should be the international standard for neurological classification of spinal cord injury. It's also referred to as INSCI and oftentimes referred to as the ASIA exam. ASIA is really stands for American Spinal Cord Injury Association. So this is the worksheet that would typically fill out for evaluation and management of spinal cord injury. It's a very complex and busy worksheet that may seem pretty daunting, but it's actually fairly straightforward if you have some experience in performing these examinations. The most important thing to recognize is that there's a motor sensory as well as a anal rectal examination in the spinal cord injury examination. In terms of the molar exam, there's really 10 muscle groups that are examining, 5 in the upper extremity, 5 in the lower extremity. The sensory examination is actually the most complicated examination, and you're testing both light touch as well as sharp sensation in the dermatome that spans from C2 to the sacrum. And in terms of the anal rectal examination, really what you're examining is whether or not they have rectal tone or any rectal sensation or rectal reflexes. So those are really the key components of a physical examination for a spinal cord injury examination. So with that examination, what it's going to tell us is the extent of the injury. And when you look at spinal cord injury, it's very important to differentiate complete versus incomplete spinal cord injury. Complete spinal cord injury really is an injury that has complete loss of motor and sensory function below the injured level of the spinal cord, including the sacrum. So the sacral examination is actually quite important to determine whether or not someone has a complete or incomplete injury. And by definition, a complete injury is also known as the ASIA examination. So these people would have no motor functions and essentially absent sensory functions below the injury, including their anal rectal examination. Incomplete injuries is when there are partial functions, including sensation only, or both motor and sensory functions below the injury level, including the sacral level. So by definition, these include ASIA B, C, and D. ASIA B is an examination where there are absent motor functions below the level of injury, including the sacrum, but they actually have preserved sensation only. Whereas ASIA C and D have actually partial motor and sensory functions. For the most part, ASIA C is an examination where patients cannot really fight gravity, so their examination is mostly consistent with a motor grade 3 or below, whereas ASIA D is grade 3 above. And by definition, normal would be classified as an ASIA E examination. So it's very important to differentiate complete and incomplete spinal cord injury, because the prognosis and expected functional recovery really is determined by the extent of the injury at the initial time of presentation, and essentially up to the first 48 to 72 hours. If you have a complete spinal cord injury that is confirmed at the initial examination, that extends to the 48 to 72 hour period, these patients have very little chance of recovery. And you can see that these are a couple slides that show some of the literature results on the potential for recovery. Unfortunately, most of these injuries are actually age injuries, and for these patients, they generally cannot decline because you can't get any worse than a complete injury. And most of these patients remain the same neurologically with, some partial improvement at best. In general, we would say that for patients who have complete injury, the chance of a meaningful functional recovery is really less than 5% in those cases. On the other hand, patients with partial or incomplete spinal cord injury, they actually have, up to 50% chance of developing some improvement, and many of which could be meaningful, particularly if they're Asia C or D. So when you're dealing with spinal cord injury, the pathophysiology really relates to two different mechanisms. The first is the primary injury, and that's the injury that occurs at the time of the trauma. And usually that's some form of contusions, bruising, laceration that leads to irreversible neuronal axonal injuries at the time of the impact and the accident. This is generally considered to be a fixed injury that may potentially improve with neural regeneration, but otherwise it's not something that is expected to make significant improvement. On the other hand, secondary injuries are injuries that occurs after the time of injury and impact, and generally these can occur because of persistent or recurrent mechanical injury. So if someone has a unstable spine after their injury, they can have ongoing compression or contusion of the spinal cord by movement. This can also be caused by ischemia or hypotension that leads to ischemic injury to the spinal cord. Excessive swelling or inflammation can also cause additional injury to the spinal cord, and certainly oxidative damages and even cellular apoptosis from acetatyl 60 is another potential mechanism for ongoing axonal or neurological injury from spinal cord injury as a result of secondary injury. So I think it's important to note that the early treatment of acute spinal cord injury is actually directed toward prevention and reversing the course of secondary injury. Again, the primary injury is likely fixed, but the secondary injury can actually be as devastating, if not more devastating in some cases. So it's very important to, number one, establish that the spine is stable and that there's no ongoing mechanical compression or injury to the spinal cord. So this can be achieved through just simple spinal precautions temporarily without moving the patient, appropriate bracing or traction realignment of the spine, and certainly it may necessitate surgery in some cases where spinal realignment and stabilization is necessary to achieve that. But much of spinal cord injury treatment in the early phase is really directed to medical treatment of spinal cord injury. So again, ischemia is one of the main mechanisms of secondary injury. So these patients really should be in the ICU to allow hemodynamic monitoring so that we're preventing hypotension, ischemia to the spinal cord. And as such, we consider central line Swan-Ganz catheter to optimize blood perfusion to the spinal cord. Although this is not a strong data, there's many anecdotal data as well as level 3 evidence that permissive hypertension, keeping mean arterial blood pressure greater than 85, can prevent progression of spinal cord injury and may improve recovery. So we generally use some type of IV pressor such as phenylephrine or norepinephrine to improve the blood pressure and blood flow to the spinal cord. And inflammatory or oxidative damage is also another important mechanism of secondary injury. So, as many of you are aware, corticosteroid was considered the standard treatment for spinal cord injury in the 1990s and early 2000s because of the North American Spinal Cord Injury Trial of 1, 2, 3. And it was considered the standard because the data show some conversion improvement rate as well as neurological improvement of corticosteroid, but that data was subsequently refuted because of the quality of the data, as well as some of the transparency issues related to the research study, as well as lack of conservation for the complications that may be related to high-dose corticosteroid. So in today's world, corticosteroids are not considered the standard of care for spinal cord injury, although it is still very frequently used. And I do think that there are many basic science as well as anecdotal data that shows that for the appropriate patient, corticosteroid is a medication or treatment that can be used for prevention of secondary injuries for spinal cord injury and to improve neurological recovery from spinal cord injury. GM1 ganglioside was another molecule that was used for its anti-inflammatory as well as antioxidant purposes. These trials were done very similar in the time frame as the corticosteroid trials. Unfortunately, there were no significant improvement from a neurological improvement standpoint in subsequent phase 2 and phase 3 trials. Gacycling as well as minocycline have also been trialed. Minocycline is actually making a comeback in terms of clinical trials related to spinal cord injury, and a phase 2 actually turned into a potential phase 3 trial in the coming era. So long-term treatment for spinal cord injury, as you know, unfortunately, is mostly directed toward rehabilitation and functional adaptation, because particularly for the Asia A spinal cord injury patients, these patients generally have a conversion rate of less than 5%, and much of the rehabilitation is really functional adaptation, not only for the patient as well as their family members. And so it is, standard care for these patients to undergo physical therapy as well as intensive inpatient rehab. So clearly, spinal cord injury treatment has not really evolved into significant improvement or recovery of neurological function in many of these traumatic spinal cord injury cases in the past. And research and development is really critical to try to optimize our ability to improve these patients' outcomes. So this is clearly an area of focus for a lot of people. New methods of focus in terms of research are still largely directed to prevention and improvement of secondary injuries. One of these mechanisms is CSF drainage by using a lumbar drain. This is actually an interesting study that we at USC have initiated and carried out in our local institution, but actually it's been studied in Canada as well as areas, some centers around North America doing multi-institutional preliminary trial that has shown some benefit in terms of neurological recovery by CSF drainage to decrease the intrathecal pressure. In addition, with the drainage, we're able to obtain some markers, biomarkers from the spinal cord injury that can help us to determine the potential prognosis of recovery, as well as biomarkers for the severity of the injury that is currently being investigated still. There's actually large trials using medications, including Radiculopathy as well as minocycline, that are being performed. The study of these studies are not yet available at this point, so we'll look forward to the results of some of these studies, hopefully in the coming months to years. Hypothermia, as you know, has had some press with one of the remarkable recovery from a couple of NFL players, actually, when they had acute spinal cord injury on the field. There are actually some clinical trials that are back at looking at hypothermia and its neuroprotective effect. One of the issues with hypothermia is that you really have to be able to introduce this relatively quickly, and obviously, with treatment of those NFL players, it was immediately recognized that they had acute spinal cord injury. The treatment was instituted very quickly. They were transferred to the hospital to receive their treatment very rapidly. That would not necessarily be practical for many of our patients that are getting injuries out in the community that may not have direct access to the technologies that these players had at the time of their injury. We at USC have been very fortunate to have the opportunity to be involved in many spinal cord injury trials. Regeneration is clearly one of the big hot topics, and we actually have a neuroregenerative center that has been involved with the Spine Center in looking at stem cells and ways to promote axonal regrowth and organization. There are more and more medications or molecules that are up and coming and looking at particularly anti-glial scar formation, because scar formation is found to be one of the major impeding factors for axonal regrowth and reorganization. So mechanisms to prevent scarring formation within the injured spinal cord is an important mechanism that many centers are looking at. And then obviously, I think rehabilitating function recovery continues to be an important part of these patients who may not have regained their ability to ambulate and move their hands and arms in a normal fashion. There's actually studies in looking at spinal cord stimulation with dorsal column stimulation to enhance the ability to gain additional functions through intensive rehabilitation. There are also developments and studies looking at the use of exoskeleton, and with the improvement in some of the brain-machine interface technology, the exoskeleton is actually one of the areas that is believed to be an important development in future for spinal cord injury rehabilitation and recovery. So as I said, we've been fortunate to be involved in many of the spinal cord injury trials because our affiliation with the USC, the LA County General Hospital, which is the Level 1 Trauma Center. One of the studies that is being performed by our institution, led by Dr. Chen, is the lumbar drain trial, where we actively drain CSF to decrease the pressure on the spinal cord and collect biomarkers to determine if this is a viable and relatively feasible option for treatment of spinal cord injury patients to improve the neurological recovery. We've been involved in stem cell trials as well as neuroscaffold trials, as well as a number of molecules that are directed at axonal inhibitory mechanisms, and all these trials have actually been very productive for us in terms of giving our patients hope and being able to participate in some of the potential development in research and investigation that hopefully will one day translate to improvement of clinical treatments for patients with spinal cord injury and their outcomes. Just to touch on a couple of these trials. So I'm sure all of you are very interested in this topic of stem cell. Stem cell trial for spinal cord injury, the one that is probably the most well known is called the OPC1 trial. Initially, this was a Geron, a California-based company that sold their rights to Asteria. This is a precursor cell that is for oligodendrocytes, which is the scaffold cells that supports the neurons in the axons within the spinal cord and the central nervous system. Clearly, this has been a pretty high-profile trial. I think in some of these cases, we have certainly seen that the use of embryonic stem cells can improve function in a limited basis. This is a press report for a patient that was treated at USC who had a motorcycle accident that was a complete injury that actually regained some function of his hands and arms after undergoing the stem cell trial in this OPC1 trial. Clearly, this is a single case that it does not determine the efficacy of this type of treatment. They're currently evaluating the phase 1/2 trial that was completed about a year ago, and hopefully we'll be seeing the phase 3 trial, which will be really critical in looking at the true efficacy across these patients with spinal cord injury undergoing this particular stem cell trial. We've also involved in this neuroscaffold trial. It's called the in vivo neuroscaffold trial. This is an interesting trial because we, for the first time, are going into the spinal cord using surgery in order to decompress the pressure of the spinal cord by, number one, opening up the dura, number two, removing the injured, contused spinal cord that may have swelling and inflammatory damage involved. And then we insert a scaffold into that injured spinal cord to try to improve the neurological recovery and hope to promote neural regeneration within the injured spinal cord. As you can see, you can see that the early analysis of this study is that we were actually able to improve the conversion rate in these patients for comparing similar patients significantly. Almost 2/3 of the patient actually had a conversion by 1 ASIO grade compared to a historic rate of less than 25%. And again, I want to caution that this was a phase 1/2 trial, that these data does not necessarily translate to the overall efficacy of this particular treatment in our general public at this point. But you know, these are extremely promising results that we hope to continue to carry forward and also bring them into our clinical practice to treat these patients on a regular basis. So, you know, in summary, I think as you are aware, these are, you know, devastating injuries that are costly not only to the individuals and the family involved, but they're also costly as healthcare stakeholders. You know, unfortunately, spinal cord injury treatment has not been as effective and as optimal as we'd like to be, and current treatment is really still largely involved the treatment of secondary injury or prevention of secondary injury. But I think what's really exciting is that there are many clinical trials in development that are actively looking at ways to improve the recovery and the outcomes of spinal cord injury. And I think that ultimately these injuries will translate, not only if they're effective, will not only help patients with spinal cord injury from traumatic causes, but I think that anybody with spinal cord injury or spinal degenerative disorder may ultimately see some benefit from that. So it's really exciting to see these research and development that are still being actively going, and hopefully we'll have more results to share in the future. And I'll end my talk there. I think we'll move on to any questions or comments.
Great. Thanks, Patrick. Great talk on obviously a devastating problem that we really don't have a solution for, but certainly there's a lot of interest. You know, we're right on the hour, so I do want to see if there's any other questions. I saw that there is a Q&A, and the two people had typed questions, and I kind of typed some answers to it, and I didn't realize that that was kind of it, meaning the question just kind of disappeared. So Betsy, how do we do it? Do people know how to raise their hand? I mean, certainly if there's no questions, we can end it, but I want to give people the opportunity to ask any questions if there's any questions.
Yeah, so in the bottom panel, you should be able to raise your hand if you have any questions, and we'll be able to see that, and I can click on it. I don't see any right now.
Yeah, what I'll do is I'll cover, you know, there were actually two questions on occipital neuralgia or cervicogenic headaches. And, you know, I will say that there's not a definitive relationship between cervical spine disease and headaches. What we do know is that if you have C1, C2 arthritis, that can cause headaches, and that's well published. And so if I suspect that they have that condition, I'll get an open mouth odontoid view. If I see that there's arthritis of the facet joints, I usually get a CAT scan just to confirm it, but I'll try like an anesthetic injection, meaning the radiologist will do a CT guided injection. If that eliminates their pain and their headaches temporarily when it's numb, then that could be the source. There's also high cervical radiculopathy. Obviously the C2, C3, and C4 nerve roots can cause some headaches or some pain kind of coming over to the head. And if you look on the imaging studies and you think there's some foraminal stenosis there that could be getting the high cervical roots, you could always try a selective nerve root block. But we typically don't operate on the neck for headaches. There's a lot of patients that have associated headaches with their degeneration. And when we're correcting their problems, a lot of times their headaches will get better. I don't see any other questions here. You know, Patrick, I guess I'll just try to ask you a question. You know, there's all these things in the news about people going to other countries and getting these stem cells, and people are paying a lot of money. And I think it kind of preys on people, because obviously if you have a spinal cord injured patient and it's your family member, it's devastating. You'll do almost anything. But I hear a lot of people going to China or this place in Europe and paying a lot of money for these people with spinal cord injuries getting these stem cells. What do you think of that? I kind of know the answer.
Yeah, well, it's obviously a very controversial topic, and it's a difficult question to answer depending on your perspective. So I think the bottom line is, from a scientific standpoint, the data is not out there to support the routine use of stem cells, in whether it's spinal cord injury, degenerative disc disease, or anything that we hope that stem cells would help us regenerate and recover, function from. I think particularly in the spinal cord injury, the spinal cord is probably one of the least studied and least understood area of neuroanatomy. We actually know a lot more about the brain circuits than we do about the brain circuits within the spinal cord. And when you think about it, the spinal cord is about a little over a centimeter in size, in the cervical spine. And yet it contains all the fibers and connection that connects all that upper executive function from the brain to the extremity. And how that is connected locally, as well as, from a complex connection standpoint. I don't think people really understand that. And to throw in stem cell, whether inside the spinal cord or outside the spinal cord, it's just hoping that the cells will find itself, it'll talk to each other, it'll make all this complex connection. And certainly I think that's a possibility, but based on all of the basic science research and clinical research that's out there, I think that's not, actually practical. I think that spinal cord injury is much more complicated than a single cell can heal in terms of the severity of the injury. So I think that, from a practical standpoint, I don't think that the scientific evidence supports that. From a patient's perspective, I think you have to weigh, the benefit and risk of, and what you're willing to invest, if you will, because I think at least today, if you had an acute spinal cord injury that's complete AJRA and you have less than 5% chance of recovery, and someone's offering this type of hope of treatment, it's hard to argue that there's no emotional reasons why you might want to try to obtain this. But from a scientific standpoint, I just don't think that it supports that, and I don't know that we can routinely prescribe and tell our patients to undergo stem cell treatment for that.
I do see one question. It says, how long does a patient use the neck brace after a fusion in the cervical spine? Do you let them do exercises without the neck brace? Patrick, what's your protocol for neck braces after cervical surgery?
I'm fairly conservative. I think that for most one levels, you probably don't need a cervical collar at all. But I do tell patients that, I think it's a good idea to wear their collar for 1 to 2 months, just to minimize the excessive movement while the fusion process is taking place, so we don't have any power or loosening issues that can lead to high risk of pseudoarthrosis. But if you're talking about higher risk of pseudoarthrosis cases, like 3 to 4 level, in those more rare cases, I generally keep these patients in a neck collar for 2 to 3 months.
Yeah, so I think that shows the diversity of opinions, because there are a lot of studies out there showing that it doesn't even matter if you use a neck brace. But I do agree with you that the main advantage of using a neck brace is that it reminds the patient that they had something done. And they have a tendency, if they're wearing the brace, not to go crazy, right? It's a lot easier for them to go and do something that puts them more at risk if they're not wearing the collar. But I usually, especially if their bone quality is good, I'll get them out of the collar in 2 weeks and start physical therapy on an early basis. I think the exception is if you've got like a construct in osteoporotic bone, it's a multiple level construct, and I'm really worried about that, then I'll probably keep them in a brace for 6 weeks, 6 to 8 weeks. And I think that's the only question. It's 6:08. the Laker tip-off is coming up very soon, and it's a very important game. So with that, I think we'll go ahead and end in our webinar. I want to thank everyone for coming. I want to thank Betsy for organizing it. Patrick, thank you, and thank myself, I guess, for speaking. As we mentioned, this is the first of a series of webinars that one of our spine faculty, Gene Techmeister, kind of created this curriculum. And so we'll make sure that we give you the announcements for the one next month. From now until May, there's a different one every month, except for September when we have two, and they're going to be on completely different topics. So hopefully we'll be able to pique your interest. So with that, as always, if there's any patients that you would like an opinion on or a consult on, feel free to send them over to the USC Spine Center. And with that, I'm going to go ahead and conclude, and let's say go Lakers. Take care, everyone.
All right. Thank you. Bye-bye.